that research is now happening in more and more types of vasculitis, but it takes time. Let's talk about the group for a second of ANCA-associated. Luis Felipe Flores-Suarez is going to tell us about that in just a moment. Wegener's microscopic polyangiitis and Scherk stress, we often lump them together because they have lots of overlap, but as he'll tell you, they certainly are each unique diseases and need special attention. So he'll talk about this. I'm just going to show you, these are all the things that can happen in the patients with these diseases. So it's an incredibly variable disease. And I'm not going to go through all of these. Some of you have some of these things, unfortunately. When you talk about the other small vessel vasculitis, they get some of those things on the list, but not all of them. But they get things like purpura. This is inflammation and breakage of the blood vessels in the skin. It's a very common finding in many different types of vasculitis. If on the skin, we can see it, we can biopsy, it's nice. If it's happening somewhere else, we might not see it for a while, might not be so good. If it's happening near your nerves, inflammation of the blood vessels around the nerves, this person can't lift his or her wrist. That's a wrist drop, not good, very painful, very disabling. These are the kinds of things that happen in small vessel disease, can happen in other types as well. Just a sampling here. This group of diseases, Behçet disease is an unusual disease that is much more common in the Mediterranean area, in Turkey and Iran and Iraq and in Greece, where you get ulcers of the mouth, of the genitals, you get skin problems, you get lung problems, you can get brain problems. It's a different form, more common in other parts of the country, other parts of the world. Polyarteritis nodosa has been known about for years and years. Medium vessel, I'll show you something on there. We have some sessions on that. Kawasaki's disease of children, and thromboembolitis obliterans question is vasculitis as opposed to a vessel problem that's a little different. Here's an oral ulcer. Could also occur in other types of vasculitis as well. Very painful and annoying. Inflammation in the eyes, very serious. Got to hop right on that. Many types of vasculitis causes inflammation in various parts of the eyes. This is an angiogram, dye being put in the arteries. Shoot the dye and it lights up in the arteries. What you see here is, where's my pointer? There it is. You'll see here, you see these lumpy, bumpy things? That's not what you want. You want a nice, smooth, this looks like the traffic I saw on 110 when I came up from the city. But this is really, what you really want to see is a smooth artery all the way. This has crimps and dilations and problems. The flow isn't good because of inflammation in the wall. This is polyarteritis nodosa. This is a child's coronary artery, one of the vessels in the child's heart with an aneurysm, swelling from inflammation. This is Kawasaki's disease. Relatively not that uncommon in children among the vasculitides. Of the large vessel diseases, Dr. Vine's going to talk to us about that. That includes Takayasu's arteritis, giant cell, and then other forms that can include the aorta and its branches up into the head, to your arms, to your kidneys. But there's a lot, it's not just about the vessels. There's all these other things that can happen in this disease, just like in all of them. There's fatigue, there's fevers, there's all these things that happen in vasculitis. Here is an MRI of the blood vessel. The aorta, here's the heart. It's a little bit backwards, coming out like this, coming down, and you can see the narrowing. This should not be this narrow. This is incredibly tight, narrowed from a patient of mine with Takayasu's, and this means very little blood's going down to everything below the waist. That's not good. We were able to fix that, but that's not good for your kidneys, for your legs, for your intestines, etc. Serious situation. Here is narrowing for the blood vessels going to your head. And as I like to say, outside of Washington, D.C., people use the blood to their head. And so we need to have, you need to get blood to your head, and so this is not good. Fortunately, your body is pretty good at making new blood vessels sometimes and going around these called collaterals, but this is a problem in Takayasu's. The variety of vasculitis is huge, but the basic principles are similar, what I'm trying to get at. Inflammation of the vessels leads to blockage and destruction of the vessels, which leads to tissues and organ downstream not being happy. That's an oversimplification for sure, but it is a helpful concept to think about. There is more to vasculitis than vasculitis. So you're saying, he's confusing me. Because it's confusing. Because in many types of vasculitis, there's inflammation outside of the blood vessels, and it's beyond the blood vessels. And so you have to understand that not everything happens is quite some vessel somewhere else. We call it vasculitis. Again, there's no perfect name, but it involves inflammation throughout your body often, not always. Fevers, fatigue. Fatigue's a huge problem that we don't address that well, even after people are better. Nodules and masses that aren't necessarily from arterial inflammation. Joint pains. And there's a lot of other things that happen systemically. that isn't. So what about treatment? Then I'll wrap up. So the basic principles of treatment are that you want to reduce the inflammation. You want to do it as fast as you can most of the time, short-term, quick benefit. Usually that means prednisone or something like it. You want to suppress the immune system for a longer time so the inflammation doesn't come back, so the disease doesn't come back, and you get a longer-term benefit. And you want to, treatment will depend on how bad things are. There's some mild cases, mild forms. Sometimes you don't treat if you know it's a drug and it's going to go away. And if it's not as severe, we use less severe medications, but when it's very bad, we tend to hit it very hard. And so it really depends on how things are for each patient. What are the goals of treatment? The goals of treatment are similar for every one of our diseases, similar for other diseases as well. You want to save a life. Clearly, that's important. That's what you want to do if it's life-threatening. It's often not life-threatening, but you also want to prevent permanent damage in tissues and organs. And you want to prevent damage from the drugs we give. So there's a balance. If we gave everybody 100 milligrams of prednisone every day for the rest of their lives, they might not have a lot of symptoms, but they'd have all these horrible problems with prednisone, and that would be worse than the disease, so you have to balance it. And you want to preserve and improve and restore the quality of life that people often, when they're sick, don't realize that they've lost. They forget what it's like to feel good. And you want to prevent relapses. That's our biggest challenge now. You really also need to avoid undertreatment. Some people just aren't treated. These are bad diseases sometimes. You need to give enough of the drug. On the other hand, we also see a lot of overtreatment. You don't necessarily need to be treated forever. Some people do, but not everybody. And you need to also avoid overtreatment. It's a nice balance. Standard treatment for severe cases of vasculitis, we try to induce a remission. We call it remission induction for about 4 months, and then maintenance for 12 or more months, sometimes a lifetime. We use a lot of steroids, glucocorticoids. We'd like to avoid using those and hopefully find ways to cut down, but they're very helpful up front. You're going to hear about data for cyclophosphamide and rituximab at this meeting. Rituximab is a new, exciting treatment. You're going to hear Dr. Spex is going to talk about that tomorrow, and that's for some forms of vasculitis. And then we use other drugs that are not quite as intense for maintenance of agents. I'm not going to go, this is just the 101. The idea is you hit hard, then you do something milder for a longer period of time. And notice that the picture of the steroids is going narrow and narrow because the dose is getting smaller and smaller. Experimental therapies might be appropriate for you. You might want to join a study, and it might be appropriate if there's no obvious treatment. For not so severe cases, we often skip these stronger stuff and go to still important and still potentially toxic medications. And for some patients, either mild flares or some forms, we only use steroids. And often what we do is we bounce around with them a little bit at the lower doses. Yeah, we're looking at lots of things. We've got lots of new drugs to look at. It's a rare disease, so I'm going to talk tomorrow about the different exciting research that's being done worldwide now, but it's very hard to do these studies. It takes us a long time. You're going to hear the results of a rituximab study. It took us 5 or more years to get that done. And so you're going to see this. You're going to hear about a lot of different agents we're talking about. Notice there's a lot of anti-things, and that's because we're trying to target the immune system. The goal of new therapies are better, less toxic. They also tend to be kind of expensive, but that's a separate issue. But we're also learning how to use some old therapies as well and try to use them better. What do we need to do? We need to find less toxic regimens. We need to find drugs that don't cause sterility, that don't reduce the ability of a woman to have a child down the line, either right away or reduce, or for men as well. We need to get rid of steroids. And we need things that just aren't as toxic. And we need drugs that you can stay on for a while and prevent relapses. That's our biggest challenge, I think, of anything. Because we're doing very well in getting people in remission, but then they come back out. We need to treat exceptionally resistant disease. We have some people with very severe disease we can't handle. On the other hand, we have people with mild, moderate, some of you would probably have that sort of grumbling, annoying, but it still requires some treatment, and it adds up. It adds up psychologically, it adds up physically, it adds up in many ways. And we need some better non-drug therapies with surgery and other interventions. And you're going to hear from some of our surgeons. Dr. Lubavix is here, ENT surgeon who has vast experience with this, et cetera, other approaches to treating the disease. So, just a couple of terms. Remission. Remission means no active disease. You can be in remission on drug or off drug. You want to be in remission. Relapse. You were in remission, now you're not. Your active disease. That's a relapse. A flare is very similar. A flare could be that you just got worse, you were still active, or a relapse is a form of a flare. 90% of patients with most forms of vasculitis will go into remission, but more than half of them will have a relapse. Glass half full, glass half empty. The goal is to get that 90 up to 100 and get that 50 up to 100, get that 50 down to 0. Persistent low-level disease is a problem, as we talked about. So what kind of doctors treat vasculitis? Why are there so many different doctors? Well, I think it's safe to say that we're generally extremely intelligent, good-looking, and generally fantastic individuals. But that's data-based. That's evidence-based statement. So rheumatologists, I read the talk, I get to say what I want. Rheumatologists treat all forms of vasculitis and usually lead the treatment team, but not always. Many of you may be treated by nephrologists, kidney doctors. If you have a form of vasculitis where the kidneys are an important part, that may be a nephrologist, and they often lead as well, and we work closely with them. Other specialists are important in the care of patients with vasculitis, usually don't lead. Dr. Spex is an exception in the pulmonary world, but in general, pulmonologists, ophthalmologists, eye guys or gals, neurologists, ear, nose, and throat, they are happy to consult and are a very, very important part of the team, but they'd like the nephrologists or rheumatologists often to run the medications. This is just to show you, this is the team we have at Boston University. This is the group of people who have particular expertise in vasculitis, because we see a lot of our patients, and it takes a village to do the entire treatment. And you really want people who know the disease, like the disease. Oh, you're seeing my advisors down here? Yeah, so I have, it helps. And if you're going to take the government's money, you really ought to go to the top to get advice. But it really takes a whole group of people who are dedicated and know the disease. You don't want to send a patient to someone who says, oh yeah, I heard about that in medical school once. And that's not necessarily what you want. They may be fine physicians and they may be useful, but you want people with some experience.